Okay, it's time to this session. I'm Youngsang from Korea, in charge of this session with Judge Woo. First speaker is Youngsang. He is a spelling surgeon. I worked at Spine Center in Youngsang General Hospital. Okay. Please.
Thank you, Chairman, and it's an honor to be here to share my experience in spine surgery. In my life, this is the first time to present in front of too many neurosurgeons. I'm an orthopedic spine surgeon. Please take care of me softly. I'm from Youngsang Hospital, located in Songnam City, south of Seoul, where 2 million people live. Today, I'll talk about degenerative lumbar spine surgery. Fusion is regarded as the gold standard for the treatment of spinal fractures, fractures, and scoliosis. For this reason, fusion is often regarded as the best way for treating spinal stenosis as well. Degenerative spondylolisthesis results from facet joint arthrosis or disc degeneration and can be treated with decompression and fusion or decompression only. Decompression and fusion can relieve back pain and radicular pain and also provide stability. But risks include adjacent segment problem, long operation time, extended hospital stay, and higher costs and also pseudoarthrosis. This is a case of 55-year-old woman with multiple fusions due to ASDs. Take right after the first surgery, 4 years later, there's ASD, and extended fusion, and 9 years after, the decompression and fusion were done again. And 12 years after the initial surgery, fusion with PSO was done again. She had 4 surgeries within over 12 years. This is a case of pseudoarthrosis 5 years after the operation. According to the domestic meta study, operation time and hospital stay are longer in fusion. Inoue reported the same result in 2018. Another study reviewed that cost, hospital stay, and operation time are also higher in fusion surgery. On the other hand, decompression alone can reduce radicular pain and clavication, but back pain may remain, and if the decompression is excessive, instability can occur. Since 1998, when I began my career as a spine surgeon, my journey in spine surgery is to find out a way not to fuse the motion segments. This image is done by AI, younger surgeon. Around 2003, I encountered lumbar TDR, and it impressed me as it seemed to align with my goals. This is one of my cases at that time. The results were quite good, however, the environment of our country didn't favor lumbar TDR. Furthermore, in recent years, the indications for TDR have become very limited and strictly controlled. Therefore, I applied another non-fusion surgical method, that is the pedicle-based system. I met Dr. Dubois. He is the developer of this system last year. We talked about the problem with this system. He agreed. A good idea doesn't always lead to good results. The ideal and the real situation can be different. I treated these patients with this method for several years, but it didn't yield satisfactory results. Some cases showed periscral halo, and it failed to prevent adjacent segment disease. Around 2000, I applied the interspinous soft spacer to my younger brother because he has a huge disc. It has shown satisfactory results for him until now, happily. He is an OBGYN doctor and still plays golf well with me. I used this method for several years. However, However, in some revised case that I done, I found the spacer was too hard compared to the initial flexibility. I expected the spacer continues to sustain its flexibility, therefore I stopped using this device. This way, my journey in spine surgery up until encountering semicircumferential decompression in 2006. I visited Hiroshima and I met Dr. Sugiya and I adapted his policy to my patient. Posterior spinal stability is maintained by the posterior ligament and facet joints. We are going to review some biomechanical studies. According to the cadaver study by Agumi in 1990, resection of the supra and interspinous ligaments does not affect spinal stability. Over 2003, Gender reported that the axial rotational instability was increased after heavy facetectomy. Research by Hamasaki in 2009, instability was observed even with 1/3 of medial facetectomy. Okuda reported that spondylolisthesis accelerated chondrogenesis and ossification of the ligament flavum. He also reported that a decrease in this height results in ligament flavum bulging and increased lobar compression. Semicircumferential decompression can be referred to as a total en bloc ligament flavectomy. This is a picture of SCD. Partially remove the spinous process first and to gain the vision for the operation, and detach the yellow ligament from cranial to caudal as you see. Under the microscope, a dome-shaped laminotomy was performed, and the cranial was detached with a curette. This video clip is about SCD first. Perform proximal dome laminotomy with a burr. And then use a curved curette and 2 mm punch to dissect the inner area of the lamina. This is a picture of detached lower portion, and this is for the right subarticular portion. Remove the opposite side, same way, and then perform envelope removal. This is just a microscope to detach both lateral sides like this way. This is a video clip that I have told. After remove and check the lobar passage. And then take out the remnant of the ligament flavum. This is a picture before remove, during the detach, and finally remove the yellow ligament. This is a schematic drawing of the procedure, and this is a picture of detaching the very thick ligament flavum. Pre and post of CT and MRI images are compared. We can see that decompression is successful and with the facet joint preserved. This is a 3D CT after L4-5 decompression. Using this method, I reported a treatment result for patients with degenerative spondylolisthesis. From 2010 to 2013, 19 patients were treated. 37 months follow-up, and all cases were rated in grade 1. All patients underwent total en bloc ligament flavectomy, and all cases were rated grade 1 and preserved facet. Fast score and ODI was measured to determine the clinical outcome. Person sleep and sleep angle was measured before and after the surgery to evaluate the stability. The person sleep by tailored method and the dynamic person sleep was measured. The sleep angle was measured by the Boxall's method. Best score and ODI of back pain and radicular pain were significantly improved. There was no significant difference in radiological parameters. This shows that post-op stability has not occurred. This shows good clinical outcome and no instability. After that, we analyzed SCD in patients with two-level degenerative spondylolisthesis. From 2014 to 2019, 14 patients were treated, followed for 28 months. All cases were mildly grade 1. The result was same in one level as SCD. There were no significant change in sleep percentage or sleep angle postoperatively. And I applied SCD and lateral fenestration technique for central and unilateral foraminal stenosis. As you know, we usually perform fusion. In Korea, central stenosis combined with foraminal stenosis is the main cause of fusion. The surgical technique is like this picture. SCD combined with lateral fenestration. This is a CT and 3D CT imaging. This is one of our cases of spondylolisthesis and complete block in myelogram. MRI of the patient, you can see the foraminal stenosis with lateral recessive stenosis. As in the case I presented, we applied SCD and LF technique to 15 patients from 2014 to 2019. The result was the same as the previous SCD studies. Despite good outcome, there were some obstacles, such as only foraminal disc recurrence and synovial cyst. This 75-year-old male patient has 3-level stenosis and 1-level unilateral foraminal stenosis treated with SCD and LF. Post-op MRI shows the quite satisfactory and good clinical outcomes. But 2 months later, the patient returned to hospital due to radiating pain again. MRI shows a newly occurred cystic lesion. So I performed another operation. I reevaluated our approach by reconsidered method. The doctor is getting older. The picture. I readapted the soft interlaminar spacer to reduce the excessive only post-op motion. I experienced only post-op synovial cysts in 4 cases with SCD and LF before, but after I adopted the spacer again, there were no more synovial cysts. This study is currently ongoing. Since 2006, I have expanded the area of non-fusion from 1-level degenerative spondylolisthesis to 2-level spondylolisthesis and stenosis with unilateral foraminal stenosis. These previously required fusion, so we can avoid complications associated with fusion. However, we still needed to solve some obstacles. I show some cases, 1-level, 2-level SCD and SCD-LF. 62-year-old female patient with back pain, radicular pain, and claudication. Her MRI shows like this. We can see right lateral stenosis and degenerative spondylolisthesis. Whole myelogram shows complete block on L4-5. This is MyeloCT, and 1-level L4-5 SCD was done in April 2018. 7 months after the operation, the patient was lost. I wondered her status before I came here, so I called her a few days ago. Now post-op 6 years. She answered me like that. She's doing well and she plays the both very well. I'm happy. This is a 2-level spondylolisthesis. This is case of 61-year-old female. Pre-op radiology data. Pre-op MRI. Post-op 1 year, there's no difference in sleep percentage compared to before the surgery. Flexion extension lateral shows no excessive motion. This is the last case for SCD-LF, 72 female, all MRI. I did SCD on L4-5, and I did LF on left L5 SCR. Also, there's no radiological change. SCD is a total envelope ligament flavectomy that preserves the facet joint and its application is currently being expanded. It improves clinical outcomes and does not cause instability. The application of SCD is expanding from one-level degenerative spondylolisthesis to include two-level degenerative spondylolisthesis, central stenosis with unilateral foraminal stenosis, and recently I applied bilateral foraminal stenosis also. This method is an excellent alternative to fusion surgery. 2004, when I was in Chicago, I met this Dr. Fujiwara. He is come from Hiroshima, and I visited his hospital in 2006. I met Dr. Sumida, and he passed away several years ago. Thank you very much.
Thank you very much for the presentation. Proceed. Is there any question or comment? Okay. Yeah.
Thank you for your presentation. I think the semester preferential proportion is very good. Do you think there is an endoscopy method to do this, or is it always fully microscope for you?
To my junior, you should learn how to do the endoscopic surgery. But for me, previously I did one portal PLD before, but these days biportal endoscopy is popular, and another Korean surgeon showed the envelope total deductive phlebotomy by endoscope last year. But for me, the learning, two things I don't want to do the scope. One is X-ray exposure, and another one is there's a learning curve. Because I do these things and do better way, but I don't think harm during my learning curve. So that's my answer.
So one more question, Professor. Do you still do fusion?
Sorry?
Do you still do a fusion for other cases?
I used to fusion, but recently the fusion rate is decreased under 5% to degenerative disease.
Good. Yeah.
Thank you for your talk. It was excellent. Are there any indications when you look at the patient's imaging or perhaps their characteristics where this isn't appropriate in your mind? Are there any, perhaps the vascular orientation and the significance of the patient?
Sorry, I cannot hear, so please speak.
Are there any factors either on imaging or within the patients where this is not appropriate that you find that actually you still have to do fusion surgery?
You mean the indication of my fusion surgery?
Yes, what are your indications in a grade 1 degenerative spondylolisthesis for a fusion? Is there any indication for you any more to do a fusion?
Previously, I did fusion also. Until last year, I did fusion for bilateral foraminal stenosis with degenerative spondylolisthesis. But as I showed you, I increased the area, so now I did both foraminal lateral fenestration and central decompression and no fusion. But the study is ongoing now, it's already about 1 year, so I try to follow more and more. But usually I did fusion, but recently under 5% I do fusion. When I do fusion is also I told you fracture infection or tumor, that's okay. But in the degenerative spine, I should think about differently because the patient doesn't know her X-ray imaging usually. Just only complain about leg pain or calculations only. So my point is to cure that point is enough. Do not make the X-ray better. I'm sorry.
Thank you.
Okay. Thank you very much. Yeah. Now, certification.